I've been doing nursing for almost 40 years. I also got my MP in critical care 20 years ago. So I've been around quite a bit. So I'm teaching this 1 hour of Oxy, and Ms. Garrettson's going to come in next week and teach you the 2 hour. I'm just going basically over the anatomy and stuff and just some formulas and things you need to know. After that, I teach all of Oxy 2. So you'll see me again. On this Oxy 1, we're talking about respiratory distress and ARDS. You've got to look at everybody's got to look at the anatomy again. How many of you went to the site, the Canvas site, and printed the PowerPoint off that? Okay, if you printed the PowerPoint off that, you're doing well. There's also a couple of other things on there. There's a handout on oxygen. There's also a ratio for oxygen to liters, another handout. I highly suggest you look at them. We also put up a video. It's on Oxy 1 only. So this is kind of hard. You're not going to absorb all of this in 50 minutes. It takes a while to sit there and look at it. So unless you looked at it before you came in here, it's going to kind of floor you a little bit. So with that, if you look at this picture and you see, don't even read the writing. You see all these things up here. This is on a normal person breathing. He needs all those things to breathe. When one of those is not working, he's going to have to be intubated. And then he's only going to have one thing coming down. And we're going to have to regulate that. So, what puts us in that? If you go back to your anatomy, we had those things called cilia. And I just refer to them as like seaweed in an aquarium. And it's just floating around, and it absorbs a lot of the toxins in the aquarium. Here, as you get older, that cilia decreases. If you have autoimmune diseases, if you have trauma, if you have cancer, whatever, that will decrease. And if you don't have that filtering all this stuff in here, you're going to wind up with pneumonia and other things. Okay? Basically, anatomy in a shell. Down here are the ducts. They just look like a clog of grapes. What I want you to know is if they look like dried up grapes, then they're bad. Okay? They're supposed to be fluffy and out like this. And why do you need to know all that? Because of these effects of aging. And if you just briefly look at this, look at the first one on the body changes. What do you see on there that is different than the rest? The increased diameter, right? Then when you go down to defense mechanisms, everything down there is also decreased. So, if you were to get a select all that apply, it would probably behoove you to see these. And basically, that is the older person that is either slumped over or has the big belly after 40, that kind of thing. Bone issues. That cilia is not going to be working. We don't have that anymore. You're going to have your cough reflex is going to be a lot different than an 18-year-old. Your immunity is decreased. You can't feel things in your throat. I did an EGD on a patient, it was my oldest patient I've ever had, and she was 108. And never been to the doctor, never took any medicines, looked like she was 60. I mean, talking, walkie-talkie, everything. And but when we went down in there and looked at that EGD, it looks very different. It's very thin, fragile. So remember that about your older patients. All right, here's another picture for you. And y'all have had this one before too, the flow of the blood. And I'm not going to go back over that today. That's all in the video, like in real easy terms. How do we diffuse this gas? What are we doing with it? How do we exchange it? One is capillary, and the other is cellular. Here's something that you might see, you might not see. I haven't had a student come back and tell me that they've even seen it on NCLEX. I've never heard of it being on NCLEX, but anyway. This has to do with the way that O2 is transported. And it can either be hooked up to the hemoglobin, or it can be in the blood. In the blood, we measure it with ABGs. With the hemoglobin, we can do a pulse ox. They have two shifts, a right shift and a left shift. And the only thing that might be beneficial there is the right shift is fever, sepsis, intense exercise, mountain climbing, that kind of stuff. The left shift is more like hypothermia, low CO2. So now what I want you to do is on a sheet of paper, we're going to do this case study and write down everything that sends a red flag to you. Mrs. G, a 72-year-old female on a med-surg floor, was in the hospital 3 days for pneumonia. She's got a continuous pulse ox, she's getting O2 at 2 liters, and she's getting antibiotics. Chest x-ray showed no change. She has a history of chronic lung disease. At the beginning of the shift, the nurse hears the low alarm of her pulse oximeter, indicating a reading of 89 to 90%. On assessment, she finds the patient alert, oriented, no apparent distress. Heart rate is 96, respiratory rate is 24, diminished breath sounds, blood pressure 124/80, and her temperature is 38.1. The nurse is unfamiliar with this patient, so she's talking to the respiratory therapist that's there with her. And she's concerned about the pulse ox, and the respiratory therapist tells her that her values are always low and close to her baseline of 92. The nurse wonders how to interpret the patient's pulse oximeter values in this context. She remembers something about the oxyhemoglobin dissociation curve. So let's go a little further with her. Mrs. G's SpO2 is in the 80%. Vital signs unchanged. Doctor calls, he wants a urine culture, and he wants another IV and antibiotic. The nurse clamps the catheter and then comes back to get urine, and there's not hardly any urine in there. Mrs. G remains alert, but seems a bit restless. The nurse helps her to the chair to eat dinner. 20 minutes later, the nurse walks by and she sees her slumped over in her chair and unresponsive. She calls for help. She tries oral suctioning. Patient still unresponsive. Because Mrs. G has a do not resuscitate order, no further interventions are taken. The nurse calls the patient's husband. When he arrives 30 minutes later, he tells the nurse, "I know you gave her good care and probably didn't know she was going to die, but I would have liked to have been there when it happened." So let's go back and look, because that's what she did. She realized that she missed a bunch of clues. Number one, she's a COPD patient. She's 72 years old. Her pulse ox was low then. Her respiratory rates were 24. Chest x-ray isn't changing. She's still on 2 liters. An 89 to 90% is, I would consider that being in trouble. What else did we see here? She has no distress. Her heart rate went up. She's got a low-grade fever. Here she talks to the RT. What she should have been doing was seeing that this pulse ox had a trend and it was going lower and lower and lower. Now it dipped down to the 80s. She starts getting no urine in that catheter. Red flag number 2 in there. Your kidneys will not play if everybody doesn't play. So, kidneys are going to shut down. You're not going to get any urine. And it should hit you, why am I not getting urine? Then, now you see her and she's a little bit restless. She wasn't restless earlier. And restless is one of those signs and symptoms that something is going on with your patient. Be it neuro or trauma, whatever. Just remember, if you see an adjective that says anything restless, anxious, pretend you're looking at that patient right in front of you, and what are you going to do? Now, she was a DNR, so they couldn't do anything. But if you go back in her history, she could have probably started calling for help when the O2 started dropping. Okay? When the urine stopped making. When she started getting confused. All right. I know you guys have had ABGs before. Here's another little picture of ABGs. If you do not know your ABGs, you better spend this entire weekend learning your ABGs, because you're going to see it on every test. Not just this test, it's going to be on every test. They're going to combine the ABGs with whatever. So learn those numbers. Learn those numbers. Here's another one I'm sure you've seen. I think this one is in the book too. With the arrows, if you need to learn it, with the arrows. Compensation. Full, non. And for that, you're going to have to look at the labs, at the ABG results. Okay? We've got it a lot more in depth on the video. All right. Distress versus failure. Distress is when, even if you give them some oxygen, they're still having some difficulty breathing. Failure means they can't do it at all. You know, their whole entire system is going to collapse. So, let's go back to Mrs. G. Look at the distress, the very first signs for distress. Tachy, stridor, wheezing, agitation, delayed capillary refill, and pale, and nasal flaring. This is when they're getting distressed. When their respirations are higher than 60, when they're grunting, when their skin is mottling. And if you don't know what mottling is, you might want to look that up, what it looks like. Head bobbing, they're trying to get the oxygen. They have that severe air hunger. Blood pressure starts dropping. Why? Because we're sending everything back up there to help the breathing. Then they go into a full-blown arrest. What color are these people going to be? Gray. Okay? They might get cyanotic, but they're going to get gray. No air movement at all. And see if that nurse would have seen the change in that patient. She could have probably prevented that arrest, and her husband would have probably been able to talk to her before she died. All right, what causes failure? You can't breathe, or we can't breathe for you. And look at that, your PaO2 is less than 60. And your pH is less than 7.30. Types of respiratory failure. Pneumonia, pulmonary edema, smoke inhalation, ARDS, PEs, high altitude, hypoventilation. Type 2, fever, sepsis, burns, drug overdoses. If you notice, it's got MS and Guillain-Barré. Anytime you have a patient that has Guillain-Barré. His partner, you might just remember it, is paralysis. Because these people have a tendency to start getting paralyzed from their toes up. So if you see decreased sensation on this kind of a patient, you better start looking at him very close, or you're going to be intubating him soon. Here's just another graph on it for you to look at. They can be chronic, which is days, or they could be acute, which is minutes. So, how are we going to assess this patient? Past medical history. Mrs. G, we did her COPD, right? Probably no smoking, no drinking. You're going to ask all these questions. Is your patient obese? We used to have this saying when we used to bring a person back for triage, and we didn't have the person with us, but we'd go back to see if there was a bed to put them in. And the nurse that was assigned to give out the beds says, what's the patient look like? And we used to say he's a 240 patient. 240 cholesterol, 240 blood pressure, 240 pulse, 240 weight. So you get the picture. So that meant he had all these risk factors. He needs a bed. Medications, what are they taking? Are they an asthmatic? Do they take inhalers? Number one thing I ask with an asthmatic, have you ever been intubated? If you've been intubated once, you've probably been intubated more than that, or you stand a good chance. If they've been intubated 12 times, I got the doctor over there at my side because they know that they're going to need to be intubated. They get intubated for a couple hours, go up to ICU, and then go home. Surgeries, if they had any type of chest surgeries or belly surgeries. Now, let's go to the objective. Remember neuro, what we saw in Mrs. G, that restlessness. Okay? A little bit of confusion. She didn't make it to seizures yet. But that should be another sign that's coming up. Skin. It can be cool, cold, and clammy, or it can be warm and flushed. It can be swollen. Respiratory sounds. You probably should hear something in there, either the wheezing, the stridor, the coarse, or nothing. And when you're looking at them respiratory-wise, if you had this patient in front of you and they said the patient has tracheal deviation, according to this, that's, you know that's bad. So you're going to be getting ready to intubate this patient. They're going to retract their muscles, their neck. That's why when you look at the patient, you always say no tracheal deviation. You can spot that the second you walk in the room. I've only seen it like 3 times. And it's very noticeable. And these people usually don't live. Cardiovascular. Their pulses. Do they have any JVD? Any pedal edema? If they start not getting enough oxygen, then they're gonna, their heart rhythm is gonna go a little bit wacky. That's why a lot of times when people come in and they're anemic, the first thing a lot of the people do is put O2 on them. And that's the reason, because it takes a lot of effort to get that. GI. Remember what I said, that older, the big belly, Same thing here. You could have distension, ascites. Be sure you address the vowel sounds. Here's another formula that you need to write down, and you have to know it. And that's a PF ratio. All of you in here probably have close to 500. Let's make a 4 an 8. If you look at the point system. If you are getting bad and totally helpless, it's going to be less than 200. And less than 200 is ARDS. 200 to 300 is not doing well. So they usually say 300. As long as you're at 300, you're better. You will see that over and over. And you will get the same repeat from Ms. Garrettson next week. So what are we going to do with this patient that's having such a hard time breathing? He's going to be on cardiac monitor. We're going to be looking at his pulse ox continuously. And we're going to be checking his assessment on a regular basis, like every hour, or if it needs more than that. Is he going to need suctioning? Is he going to need BiCAP, CPAP? Do we need to intubate him? What's something that you can do to get him more oxygen? Sit him up. Everybody that's short of breath, sit them up, because it's really hard to breathe when you're laying flat. If they're going to lay on their side, let them lay on the side of their good lung. Good lung down. Hemoglobins need to be higher than 7. You may have to give some blood. Vasopressors and fluid is going to help this patient. How are we going to decrease his demand? What can we do for this patient to decrease it? One, we can let him rest. That means don't bother him every 10 minutes. Treat his fever. Most of these people wind up with sepsis. We got to treat that cause. Everybody from here on out this semester, I don't care what lecture you're in, find whatever kind of diet they're on. Because NCLEX wants you to know diets too. So all these people have to eat. They have to breathe and they have to eat. So these people, we're going to put them on a low carb feeding. Tube feeding. Low carb. What caused this failure? If he's got something going on with his mouth, these are people that really need to have their mouth cleaned. Nutritional support. Fluid, electrolytes. All right, ARDS. Acute respiratory distress syndrome. You guys have seen this because of COVID. And this is like the worst thing you could get. You really don't want this. It doesn't come from fluid overload. It doesn't come from heart problems. It comes from an inflammatory response related back to that capillary membrane that we looked at earlier. The classic sign of ARDS is a low PaO2. So look at your patient and decide if his PaO2 is low. He could be in ARDS, even though we have him on oxygen. These people, it's a very, very high mortality rate. But you guys know that too. All right. Look at this x-ray. Look at the one on the left. This happened a couple of weeks ago. Look at his lungs. And you don't need 8 years of medical school to read an x-ray. You can just look at the picture and see something's not right. Here, you see a little bit of white coming in here, a little there, but the majority is black. This one is black. What do you see on the right one? Does everybody see there's a distinct difference in these two? See, I told you could read an x-ray. You just know that they're not. If you're looking at your patient the second day and he's looking like that, and the doctor hasn't made rounds yet, you can say, oh my God, he's getting worse. So you can anticipate you're going to be doing a whole bunch of orders, okay? Because all of this is white out now. Look at, and some of the things that can cause ARDS, sepsis is the number one. Aspiration. Go back to the beginning on age. They have difficulty swallowing, so they're at risk for aspiration. Pneumonia. Trauma. Drowning. Pancreatitis. And overdose. They could have also been in a fire and breathed in some stuff. It also can come from transfusions, and you'll get that on the blood thing. Okay, patho. This is still letting all that fluid, the cells gang up, and they push and push and push, till one of them can get through, and then the rest get through. And you wind up with some of that pulmonary edema in there. MODS. Do you guys know what MODS stands for? Multi-organ dysfunction syndrome. And basically what that means is if one organ shuts down, the others are going to follow right behind it, okay? They all have to play together. You can't have a team. Phases of ARDS. There's 4 phases. And these, I think, are in your book too, but this is also on the PowerPoint that you can look at it. You can see on this one where the pulmonary edema has started coming in. It looks different. None of these look really good. Everything down here is totally collapsed. Now let's look at this chest x-ray. Look at the first one on the left. Now look at the one on the right. Which one is he getting better or worse?
Worse.
Worse. Look at this one.
Better.
Is he getting better or worse? Better. He got some treatment in that first one. And that's what you're going to be doing to look at the x-rays. That's all you need to do. You can read those. How are we going to manage this patient? Intubation. They're going to get small tidal volumes on the vent and a high peak. And they're going to be sedated. Miss Garrettson's going to come in next week, and you're going to get the whole ventilator lecture and probably still some of this with it. Remember, we got to watch his fluids, and we got to protect all those other organs. We can give him diuretics, fluids. How are we going to prevent any problems? Tube feeding. Low carb, high fat, and protein. PPI. Why are we giving this patient a PPI? Everybody in the ICU gets a PPI. If your leg's broken, you get a PPI. Because that causes, your body has stress when it has trauma to it. Even though you're cool as a cucumber, you're not going to get any ulcers, but your body is going to get an ulcer. How do we treat some of this? Lovenox, positioning these people around. Now, prone position. This is like the worst thing. Usually, by the time you got them in prone, they're not doing well. And if you've got to move this patient for whatever reason, you're going to need about 6 to 8 people to move this patient. One to hold his head, one to hold his neck, his IVs, and it has to be a real all-in-one transition. The most important thing that you're doing is keeping that airway intact. So you're going to check it before you move him, and you're going to check it after you move him. Goals. Well, this one's pretty easy. You guys can do goals. Keep his airway tight. Help his breathing. Make sure he gets a good gas exchange. Make sure the tissues are getting O2. We're going to feed him. We're going to give him something for pain. We're going to give him something for anxiety. Because, I don't know about you guys, but if I had a tube down my throat, I think my anxiety, especially what I know what nurses have to do, my anxiety would be through the roof. Okay, complications of ARDS. Well, that's just about everything under the book. Number 1, infection. Where does it come from? Catheters. Or an acquired pneumonia in the hospital. If they get the acquired pneumonia, the insurance doesn't have to pay the bill. And like we said, sepsis. Respiratory. Their O2, they can be toxic. They can have PEs. They can get VAP, which is pneumonia on a ventilator. Look at the GI. Stress ulceration. Now you got a GI bleed. A paralytic ileus, which is never nice. And people die from that. His renal. Remember, she wasn't putting out any urine. So her renal function is going down. They can go into acute renal failure. Cardiac was the arrhythmias, right? Decreased cardiac output. Blood, anemia, DIC. The ET tube. Displacement. Stenosis. Is it ulcerated? Psychological. Sleep can make somebody crazy. So you want these people in the ICU to rest. How do you do that? Try to keep them away from all the noise. Keep the doors closed and stay quiet. On the ICU that I'm at, it is extremely quiet. Even when we've had 3 codes going on at the same time, it's quiet. You'd never know.
Much different than the ER where everybody's screaming down the hall. ICU psychosis. Everybody seems to get that. Everybody seems to get PTSD when they're in the ICU. You got to keep these people, on a rhythm. Turn those lights off at night. Turn their TV on, their radio on. Do something to where they could see there's a difference in that. So with that being said, let's do a couple questions real quick. The nurse is assessing a patient receiving 30% FiO2, admitted with respiratory distress. What findings should the nurse recognize as a worsening in the patient's condition? A is respiratory rate of 24, capillary refill greater than 3, PaO2 60, PaO2 112. What's the first thing that should jump out at you?
Camera film.
Which one?
B.
C. That PaO2 of less than 60 or less. The nurse is assessing a patient that sustained multiple trauma. Which assessment finding should the nurse correlate with the possible onset of ARDS? A, bronchi, B, wheezing, C, retractions, D, increased respiratory rate.
The retractions.
So what are we betting on? It's D, increased respiratory rate, okay? Remember, that was one of the criteria, that respiratory rate is going up. The others, you can have wheezing, but how many people in here have asthma? So, you're wheezing, that doesn't mean you have ARDS. That's why that one would not work. So, increased respiratory rate. Remember Mrs. G. Here's another one. Which statement regarding nutritional needs of the patient with ARDS is correct? A, calories are not calculated because of decreased energy. B, parental nutrition is preferred. C, nutrition has reduced fat content. D, reduced carbs. D. So you see why a diet is important. Here's another one. Y'all's favorite. Select all that apply. A patient with acute respiratory distress syndrome is being weaned from the vent. Which nursing action are you going to do for this patient? A, are you going to increase his FiO2? No. B, are you going to place him in a semi-Fowler position? Yes. C, are you going to provide all his morning care during the weaning procedures? That would be a no. Why is that a no? Because he's going to be worn out. It's hard enough to wean him, let alone, let's brush your teeth, let's get you up, let's do all this. D, begin weaning procedures in the morning. Okay, you want to do these in the morning for a couple of reasons. One, you have staff. So if it goes south, you have plenty of staff to help. And they've had a good night's sleep, or at least you hope they've had a good night's sleep. to where they're rested in the morning and ready to go and get that tube pulled out. And they usually will do this every day on a patient. Object is to get them off that vent as soon as possible. The longer they stay on the vent, the harder it is to get them off. Okay, now, last couple minutes. The oxygen that's on the wall, the liter thing, I want you to know how many liters those are. How much oxygen are you getting if you have 2 liters? How much if you have 4 liters? If you haven't had that yet to calculate, I would assume they did this in first level, but I'm just telling you again. You want to look at that because that's going to be important. If you shoot that thing all the way up to 10, it's going to blow off the wall. So usually anything after 6 doesn't work. If you're wasting your time, it's just blowing. But I have seen where we had to do it at 10. But like I said, with ours, they're still having trouble breathing, even though you've done all this other stuff. Okay, we have pulse oxes. If it's like 95%, I'd put them on 2 liters. If we go down, depending on the patient, but if it goes down to 88 to 90, we're going to put them on a non-rebreather. How much oxygen does a non-rebreather give? 100%. That's why you're going to put them on that. And you got to open up that little bag. What if they're just breathing at 97%? Would a nasal cannula work? Yes. What if he doesn't like something in his nose and he's fighting you? What can you do? You can put on just the plain face mask, okay? But that usually has humidified air with it if you go up high. We have another mask that has all these different little colors on it. And their percentages. And the doctor will say, I want them on 50% this. Don't get that mixed up with a plain mask. This one has colors. And half the time when you try to get them to move to the color, they break. But you can look at those. That's why you need to, when you go to clinical, go look at the supplies you're going to be using. How to take the O2 off the wall. How to hang your tubing. All of those kind of things, including these different ways of oxygen. Because you can always do that. And when somebody's busy, whenever you go somewhere, you need to live in that supply room for a couple of weeks. Know where everything is. So I want you to take a look at that handout that's in there. The formulas, the diet, the causes, how we're going to fix it. But if you just sit back and think about it, you know how to fix an oxygen problem. You know? We're not going to leave them laying flat. We're going to sit anybody up. So that doesn't matter till we get to the next concept and they're having heart problems. What are we going to do? We're going to sit them up. So it continues.
like I said, the whole entire lecture is recorded on there. And Garrison went into extreme detail with it. So, but this is something you're going to have to sit down in a quiet room and look at it and see it. You know, go online, look at some videos, something that you see it different ways. But you got to know your ABGs. That's really going to count on this big test.
I have a question about the ABGs. I've been writing up my notes and stuff, and I noticed that they're off a little bit. Like you have
They
lab
don't-
values here in the book.
I know,
So which
don't,
values do you want us to use?
What we're gonna do is, we're not gonna be 1 point off on a question. It's gonna be a lot of points off. You understand what I'm saying? You're not gonna have to pick between 7.3 and 7.35. It's not gonna be like that. It's either gonna be high or it's gonna be low. But that takes some work, and they do ABGs everywhere. They do them in OB, they do them in PEDS, they do them in skilled units, everywhere. So, look those over, find yourself a way to learn those. I've seen some students write the formula out first thing when they get their scratch paper before the test. You know, they're writing, they haven't even looked at the test, they're writing all those things out. That's fine, you know, if you can do it like that. But there's a lot of videos out there that go over ABGs. Nancy Nurse, or whatever her name is, American Nurse, Michael is out there, and they put it in pretty simple terms if you need to go back and review it. But you're going to have to know it. Has this person got a respiratory problem, or do we have a metabolic problem? And then from there, you can figure it out. Is this patient acidotic? Which usually most of them are. If you had to do a straight guess. But that's what's going to be on your test. Just like those questions that I read out to you. You still know the details about ARDS. What would be the number that you would worry about with ARDS? 200, right? 200. That's not very much. We want it a whole lot higher. So if you had a patient that was 400 today and he's 300 tomorrow, we know he's headed towards ARDS. Not quite there yet, but he's headed there. So maybe you can fix it. Maybe he needs another antibiotic. I was reading something from the thoracic surgeons, and they want to now do this with sepsis to where you have, they have the whole protocol sheet. Well, what they want to do is they want to include the pulse ox, and that you need to get a pulse ox on these people. And if they're low, that should go into a sepsis protocol for airway. They found that it tied pretty much with ABGs. If your, pulse ox was 99%, then your ABGs were fine. So just to kind of let you know, it's coming back in.
after we all learned how to do ABGs. Now we don't have to do them. So, that is I will see y'all probably in 2 weeks.